All right. So now we're going to talk about levels of evidence. There are many different ways you can rate evidence. Oftentimes we use the Iowa level of evidence. A lot of people use, there's so many different types. I tend to use the John Hopkins, but that's because my professors in graduate school prefer John Hopkins. There are many different ways to rate levels of evidence when you're looking at them. Okay. So I really want to touch on this for a little bit because you guys are in this point in your career, especially when you're writing papers for me and for your other professors, about levels of evidence. So the highest level of evidence is a peer-reviewed journal article that's a systematic review, a meta-analysis, a randomized control trial, evidence-based clinical practice guidelines based on a randomized control trial. Okay, they're going to be the highest rated, and you know you can use them. When you're trying to look for practice changes or you're trying to get an idea of where to start, I always go to the systematic review and meta-analysis, and you can go to the Cochrane Library and get that, and everyone has access to it. But here's the deal. These are the highest level of evidence. It means it has taken hundreds of different studies on one subject and have reviewed them and all their findings and concluded one way or another some sort of aspect of clinical care. So, and then it goes on down based on how the study is designed. Is it a quantitative study? Is it qualitative? How big was the study? Who wrote it? All the way down to the evidence being made of opinions of authorities, reports of experts. So, you know, if you are reporting, if you're talking about a practice change that's just on the opinion of a really good doctor, that's not that strong evidence in comparison to that of a systematic review, which probably has 10 to 15 years worth of studies in it. So it's really important that you understand how to rate your evidence. And when you get into graduate school, this is you have to do it, and you have to understand how you do it, because if you are using poor evidence to support any of your data or any of your reports, you won't pass, right? Because it's our job to be able to figure out what's good data when we use it to support our information. Okay. So evidence-based practice, the process of doing the right thing. Yeah, the right thing because it's based on good evidence. So we have standards of care and there's baseline description of quality. Oops. That's what standard of care is, right? It is the basic care we have to give to everyone because it is, the least amount of care you can give, that's still ethically the best care. And it may be discipline focused toward AANP standards of an NP practice or ANA standards, or, the American College of Medicine. Clinical guidelines. So these are broad-based recommendations, and oftentimes that's how we base our practice guidelines, correct? So, if some of you have expressed that you're interested in becoming a nurse practitioner, okay, well, you have to base all of your care off evidence-based clinical guidelines. Nothing like, oh, my doctor tried this once, I'm going to try it. No off-label use or anything like that, without it becoming clinically based or clinical guidelines. So, when I start screening for things, I screen based on the recommendations. When somebody wants to talk about further migraine care and they say, oh, my mom responded to this medicine, it's not based on the guidelines, we don't go that route in primary care. And even in specialty care, oftentimes you can't do that without the recommendation of a physician. So critical pathways, you're identifying key and critical activities that must occur in a predictable fashion. So when you are using evidence-based practice, it's not the crazy stuff that you're going to do. You're going to understand the steps that come in of causation, because you need to have some predictability in what you're doing because you need to keep a patient safe, and you also are liable for these changes that you're implementing. And then protocols. These are detailed procedures on how to proceed with evaluation and treatment. All right, so 5 steps to evidence-based practice. Asking the burning clinical question. Okay, so PICO. PICO stands for population, intervention, comparison, outcome, and time. All right, so what is the population you want to implement some sort of change to? What is the actual change, the intervention? What are you comparing it to? What do you hope the outcome is going to be, and in what timeline? Some people do leave out timeline, especially when they're first forming their PICO question. Again, you have to understand what a PICO question is and how to form one in order for you to successfully get through a graduate program. And I know that many of you guys want to go on and do that, and you can do that. You're going to be great at it. Search for and collect the most relevant and best evidence. Critically appraise the evidence. Integrate all evidence with one clinical expertise, patient preference, and values in making a practice decision or change, and evaluate the practice decision or change. Okay, so the first thing we're going to do is we're going to come up with a problem. Okay, so since you're not in class with me, I'm going to pretend that I'm going to come up with a problem and you guys are actually giving me ideas. So who here has a clinical problem? Oh, you in the back. I want to figure out how to decrease refill compliance in the primary care setting. Oh, there must be some really cool person in here who works in primary care. All right, so I really want to fix this, right? I want to fix refill compliance on my chronically ill patients. Okay, so that's not very specific, right? So let me look at a main problem. You have to, so you say to yourself, my patients are really bad at refilling their blood pressure medicine or their diabetes medicine or their thyroid medicine. You want to focus on one population specifically. You can go broad and say all my adult patients who have chronic disease. Fine, you can. However you want to do it is fine. Okay, now, where is it that you can develop an intervention? Well, first thing that you want to do is you kind of want to ask yourself, what are the interventions out there? So before you really get into all the relevant and best evidence, you can just do a quick appraisal. So something I like to do first, this is me looking through YouTube for y'all. I do quick Google searches, right? So improving refill compliance in chronic illness. All right. Hey, look at this, a review of literature. Those tend to be evidence level 1. And look, it's published by the NCBI, NIH.gov. NIH, National Institute of Health, we know they're legitimate, right? There's a bunch of them. All right, this is 2015, which you know is even better. Review of Lit, even better. Okay, I'm just going to scan this to get some ideas, right? I'm reading here, chronic disease management requires continuous physiologic adaptation, behavioral reorganization. I happen to be in informatics. So hey, why don't we come up with a text messaging program to remind our patients at the end of the month, have you refilled your meds? Okay, cool. So asking the burning question. You want to be real specific. So let me pull up a Word document, put this in real big font. Okay. So PICO, right? P-C-O-T. So first, population. All right. So I work in a public health primary care clinic, right? Look at my bad spelling. All right, intervention, monthly text reminders to refill medication, compare to no reminders, okay, outcome, increase refill compliance. And you can tell that by calling a pharmacy. You can call and say, how often is my patient refilling their beta blocker? And let me tell you, I do this all the time. A patient comes in and their blood pressure is crazy and they say, Dr. Denise, I am taking it every single day. And I say, you've never missed a dose of your, lisinopril. No, I've never missed a dose. Okay, well, listen, you haven't been here in 6 weeks. So that's about 42 days. In 42 days, how many days do you think you missed? 3. Great. 90% compliance. Then I call the pharmacy and I see, and I'm not doing this to be mean. Absolutely not. I'm just doing it to make sure. People forget. A lot of times you're like, yeah, I just took it yesterday, and yesterday meant 2 weeks ago, right? Because we lose track of time. And when you have a lot of medications prescribed to you, it's very easy to think that you're taking it, but you're taking the 6 other medications that you're supposed to get. And then you could say, all right, so time over a 6-month period, right? Okay. So population in a public health primary care clinic, how does monthly text reminders to refill medications for adult patients with chronic disease, right, compared to no reminders, which is the previous thing, increase refill compliance over a 6-month period? Boom. All right, we got it. That's our PICO question. Now, if you're ever out there and you're saying to me, oh my gosh, Denise, I have to do a PICO question. There are awesome different PICO, so you could do PICO question format. And I use this there's formulas, okay? So I think this is the one I always use. Yep, this is it. So look, there's intervention therapy, there's etiology, diagnosis or diagnostic tests. So let's see, are fecal occult blood stool tests more accurate in diagnosing bleeding polyps compared with a stool guaiac for average risk? Are fecal occult blood tests more accurate in diagnosing bleeding polyps in average risk colon cancer patients over the age of 50 compared with stool guaiacs for bleeding ulcers or something, whatever. So these are really good tools. I always search I get my evidence-based practice book out. And you really want to practice honing your skill. Your first PICO question is probably not going to be the final draft. And you want to make sure that you are very clear about your population, intervention, comparison, outcome, and time frame. Okay?